Barclays official California Code of Regulation focused on delegation presented by Mary Cruz Garcia and Judy Santos.
Hello, everyone. So today we will be discussing the American Nurses Association Code of Ethics for Nurses, specifically provision number 4 that talks about the effective delegation responsibility that an RN possesses. We will also be discussing tasks that can be and can't be delegated to an LVN, as well as those tasks that can and cannot be delegated to UAP. Nurses can also delegate to other staff members. However, most of the delegation tasks amongst the nurses' subordinates will include LVNs and UAPs. So Article 1443.5, provision number 4 states that a registered nurse shall be considered to be competent when he or she consistently demonstrates the ability to transfer scientific knowledge from social, biological, and physical sciences in applying the nursing process by number 4, and specifically delegating tasks to subordinates based on legal scopes of practice of the subordinates and on the preparation and capability needed in the task to be delegated, and effectively supervises nursing care being given by subordinates. So basically, as an RN, you will delegate different tasks to different subordinates, but ultimately, it is the RN's, your responsibility to be aware of your subordinate's scope of practice. The subordinates that the nurse will likely be delegating tasks to include, but are not limited to, the UAPs and LVNs, like stated in the previous slide. So as mentioned before, it is imperative for the RN to familiarize themselves with the subordinate's legal scope of practice and unique capabilities in order to promote effective delegation of tasks. There are 5 rights of delegation that help the RN use their professional judgment to facilitate effective delegation. The first of these rights is the right task. So the RN must ask themselves, does this task align with the scope of practice of the person and is in the hospital policy? So you're not going to ask a UAP to start an IV. So it's just familiarizing themselves with, again, the scope of practice of their subordinates. The second right of delegation is the right circumstance. So the RN must ask themselves if the patient is stable enough for this subordinate. Again, if you see a patient that is fluctuating in O2 levels, you're not going to delegate a task to an LVN. You will, again, we need to try to delegate patients that are stable to our LVNs. The third right of delegation is the right person. So the RN must ask themselves if the subordinate is actually capable of completing the task and meeting the patient's needs. So even though in writing, an LVN or a UAP can perform a certain task, we must also take into consideration, like if that's the UAP or LVN's first day on the job, and again, this is all to help meet our patients' needs and be safe. The fourth right of delegation is right communication. So as RNs, we need to communicate the desired task we want, and we need to communicate it well. We need to make sure that the subordinates we are communicating to are clear with the directions and make sure we follow up if there is a bit of confusion with that. And then lastly is the fifth right of delegation, which is the right supervision and evaluation. So the RN must be able to decipher if this subordinate is going to require supervision of the task, and they need to follow up if necessary and give constructive criticism again. So per the 2019 National Guidelines for Nursing Delegation, a licensed nurse is still responsible for ensuring an assignment is carried out completely and correctly. So we're not just losing responsibility, letting go of responsibility once we transfer a task. So once the 5 rights of delegation are met, again, per the nurse's discretion, the RN is basically transferring responsibility of the performance of the task but still has the professional accountability for the care of the patient, according to the American Nurses Association, of course. So more on the American Nurses Association principles for delegation, care provisions. We can use ADPI to help us facilitate effective delegation amongst our subordinates. So as RNs, we already know that we cannot delegate anything that involves assessment or initial education to our subordinates like our LVNs or our UAPs. We cannot delegate anything that requires critical decision making to them. However, once we do delegate a task that they are able to complete, we need to remember that we ultimately the responsibility that task is completed and completed accurately lies on us, the RNs. So it's very, very important that we are aware of our subordinates' legal scope of practice, and we need to know that, again, as RNs, we do have the responsibility to do effective delegation. The first step, of course, is assessing. So as an RN, we will be able to determine if we are able to delegate a certain patient to a subordinate. We must first perform an assessment of our patient or healthcare consumer's needs, condition, and we need to be aware of the environment where the care is going to be provided for this patient. So the next part, our American Nurses Association principles for delegation, can involve diagnosing and planning. So we need to develop a plan with our patient and their families and be able to identify what we want as our goal and what tasks can be delegated to different providers, care providers in the hospital, different family members once they get discharged. Again, we also need to talk to our patients and their families about appropriate expectations and the roles that our different care providers play in the hospital setting. This all aims to promote a safer environment and improve patient outcomes. To get this all started, we need to know the baseline status of our patient. We need to talk to our UAPs and tell them when they need to report back to us if there's a change in baseline status.
And continuing to using ADPI for ANA's principle of delegation, we still are in the planning and implementing phase. Um, so we'll analyze first the task that we are able to delegate. What are the state and federal laws that support this delegation? Does the employing organization that the RN is employed at and the UAP is employed, do they permit this delegation? Is a delegation delegating RN competent to make the delegation decision? Is the UAP competent to perform the delegated task? Is RN's supervision of the UAP available? Next, we'll evaluate. We'll monitor implementation of the delegated task as appropriate to the overall plan of care. Then we'll evaluate the condition of the patient. Then we'll evaluate the UAP skills and performance of the task. Next, we'll expand about the LVN scope of practice. As defined by the vocational nurse program established in 1951, it is currently being regulated by the Board of Vocational Nursing and Psychiatric Technicians. LVN scope of practice in California, they can provide basic nursing care under the direction and supervision of an RN physician. They can use their scientific and technical knowledge and manual skill to perform tasks, provide basic hygiene and nursing care, measure vitals, provide basic patient assessment after the initial assessment, administer oral medication and other non-IV therapy, and they can perform blood draws with the caveat they would need a phlebotomy license. Functions of a UAP are actually defined by the Board of Registered Nursing. Functions not performed by an unlicensed personnel include but not limited to administration of medication, venipuncture or IV medication, parenteral or tube feedings, invasive procedures including inserting NG tubes, catheters, and tracheal suction, assessment of patient condition, educating patients and their families concerning the patient's health condition, and moderating complex laboratory tests. So I pulled a couple NCLEX examples for all of these situations as practice, I guess. When so the question is, when care assignment are being made for patients with alterations related to GI cancer, which patient would be the most appropriate to assign to an LVN, LPN under the supervision of the team leader RN? The patient with severe anemia secondary to GI bleeding, patient who needs enemas and antibiotics to control GI bacteria, a patient who needs preoperative teaching for bowel resection surgery, or a patient who needs central line insertion for IV therapy. So the answer would be enemas and antibiotics to control GI bacteria. Though that some states allow LVN and LPNs to administer blood, in general, administering blood, providing preoperative teaching, and assisting with central line are the responsibilities of the RN. Here's another example in regards to UAP. The patient's nursing diagnosis is deficient fluid volume related to excessive fluid loss. Which action related to fluid management should be delegated to the UAP? Administering IV fluids as prescribed by the physician, provide straws and offering fluids between meals, develop a plan for added fluid intake for over 24 hours, teaching family members to assist client with fluid intake. So the answer would be to provide straws and offering fluids between meals. UAPs are generally, I would like to see it as like some of our volunteers, orderlies that don't necessarily have the training. So UAPs can enforce additional fluids once it is part of the care plan and indicated by a plan made by the care team, um, administering IV fluids, developing plans, and teaching families require more education and skill and is within the scope of an RN. Here are references, and thank you guys. We appreciate you listening. Have a wonderful day.